This is a dysphagia talk. Our first question is, a 92-year-old female with moderate dementia is admitted to the hospital for mental status changes. The chest x-ray shows a right lower lobe pneumonia. Do you order a swallowing study?
Well, we suspect there's something going on, right? With the right lower lobe, she's probably aspirating. Moderate dementia, we know that they're going to have problems with their swallow. So, I mean, I if there hasn't been one done, I would.
Okay, what do you think?
I think I'll go with Nate here.
All right. So let's find out. It's not a black and white answer. There's no right answer, no wrong answer. There are 50 pairs of muscles involved in swallowing and many, many nerves, and they have to go in just the right order for it to work correctly. So it's very frequent that as we get older, things don't go just right, or as we develop dementia, we have aspiration. So 47 women were between the ages of 85 and 94, showed that 15% had some food going down the wrong way, and 72% had something going down the wrong way with 3-ounce swallowing. So it's quite frequent. The best predictor of abnormal swallowing is a cough on swallowing, and that has a sensitivity and specificity in the 70s range, and cough on 3-ounce water swallowing has a 84% predictive value and 78% negative predictive value. So that's fairly good.
Now, are those 3 ounces spaced out, or is it kind of a continuous swallow?
A continuous swallow,
Mm-hmm.
yeah, in one sitting. Mm-hmm. So the American Speech and Hearing Association says to get a careful history of conditions and symptoms, and looking at the strength and movement of the swallowing muscles, observing the feeding, and then possibly doing additional tests, but not necessarily, such as a modified barium swallow or a lighted endoscopy to view swallow. The AHRQ says that neither video fluoroscopy nor fiber optic endoscopy can serve as a perfect gold standard for the detection of aspiration, because each yields false negatives and false positive results. A full bedside exam seems to have a sensitivity of 80% and a specificity near 70%, according to AHRQ. And the American Medical Directors Association, or the Society of Long-Term and Post-Acute Care, says that swallowing abnormalities are common, but don't necessarily require a modified diet or fluid textures, especially if that would restrict food and fluid intake in the patients. So taking a look at the whole picture is really important. Also, Medicare and Medicaid, so the Centers of Medicare and Medicaid, says identification of a swallowing abnormality does not necessarily warrant dietary restrictions, because it does not necessarily correlate with aspiration pneumonia. So ground and parade and solids and thickened liquids oftentimes increase the risk of dehydration and malnutrition, because patients don't like it and then will eat less and oftentimes drink less.
So where are all our patients in the hospital that have an abnormal bedside swallow evaluation put on thickened liquids?
Right.
Every time?
Yeah, and there are no guidelines to recommend that.
Mm-hmm.
So they haven't found an association between having dysphagia and the aspiration pneumonia?
Very poor correlation, exactly. Yes.
Okay.
So we have a lot of studies showing abnormal swallowing with the video fluoroscopy, but very little correlation with aspiration pneumonia.
Okay.
Yeah. And there is little to no long-term evidence that interventions prevent aspiration pneumonia. And only scant evidence suggests that thickened liquids result in positive health outcomes. Yet we think that video fluoroscopy is the gold standard, and we use that as the go-to when there is very little evidence of any benefit. So in this study, 711 patients with dementia or Parkinson's between the age of 50 and 95 were identified by speech pathologists with aspiration. So they put them into various different thickened liquids and chin down procedures. And aspiration occurred in honey thick liquids at 53% of the time, nectar thick liquids at 63% of the time, and with thin liquids with chin down position, 68% of the time. So that nectar thick is not much better than thin liquids in this study. And of course, patients preferred thin liquids over nectar thick and those over honey thick liquids. Cochrane also says that there is not enough evidence to make recommendations on swallowing in these diseases, and that includes chronic muscle diseases, Parkinson's, stroke, and advanced dementia. So what we should probably ask is if our 92-year-old has a living will and what she would want done in this case. Would she want a peg? Let's say she has a living will and she does not want a peg. So ask the family or ask the patient if she can answer if she would want thickeners, if changing her liquids is something that she would be accepting of. And then maybe do a video fluoroscopy. Now, the video fluoroscopy also puts the patient at risk of aspiration during the study, but barium in and of itself is harmless if it is aspirated.
And so it would be more or less futile to do the video fluoroscopy if they wouldn't change their dietary patterns anyway, like if it wouldn't change our management.
Right. So there are some schools of thought that say that maybe doing some alternative swallowing mechanisms, such as head turning to one side or the other, or tilting the head to one side or the other, can be of benefit. So it just depends on the situation. But
how much benefit do they see?
it depends on the situation. So if a patient with a stroke has some unilateral weakness, then that probably is more benefit than in a patient with dementia. But I don't have good studies. It would probably be in the speech therapy literature in greater detail.
Okay.
But in our patient with dementia, I don't know if there would be a lot to it. Plus, I don't know how well she would learn any techniques that a speech therapist could teach her. But, we could maybe observe her and then guide her while she's eating. So look at it in the overall picture.
It doesn't seem that there are the best treatments or solutions for dysphagia. And so, like you said, in the setting of quality of life, it would make me pause before I'd want to pursue even, a video fluoroscopic diagnostic procedure if it's not going to change management, like Julia said. And if the quality of life is to eat, it almost feels like you would say, well, since we don't have better alternatives, and we can't guarantee that this is linked to aspiration pneumonia, you might be better off just enjoying your food.
Correct, exactly.
Okay.
Plus, I lost my train of thought. Anyway, exactly, that's exactly the idea. So this study looked at 40 nursing home patients that underwent video fluoroscopy, and of those that were followed over 12 months, 22 had aspiration, 15 of them had feeding tubes placed, and they had a higher rate of pneumonia and death in the ones that had the feeding tubes placed versus the ones that did not have feeding tubes placed. 17 of the 40 developed aspiration pneumonia, 18 of 40 died. There was no benefit of the video fluoroscopy and no benefit of tube placement. So we'll talk in a few minutes about things that we can do, and it does not require a video fluoroscopy. So the video fluoroscopy was never intended to be the only or even the main study to predict pneumonia. And I have not seen any studies showing outcomes, patient-oriented outcomes such as pneumonia. Mm-hmm. I've only seen studies looking at penetration upon video fluoroscopy and aspiration, but not on patient outcomes. And swallowing is conscious and cortically controlled during the study, whereas the way we eat, we're oftentimes talking and are distracted when we're swallowing, so it might be very different than it is during the swallowing. Plus, the liquids that are used during the video fluoroscopy, because they have barium added, are a little bit thicker than the liquids of the same consistency during a meal without the barium. So it may not be as accurate. This is a slide just looking at the 5 levels of the dysphagia diet that you might come across, just an explanation of what they are. So with level 1 being parade food. And then naturally thin or thick liquids. So it was surprising to me when I learned that Jell-O is actually a thin liquid because it melts in our mouth, and then when we swallow it, it's thin liquid. Mm-hmm. Same thing with sherbet. Naturally nectar-thick foods are tomato juice, eggnog, or cream-based soups. There are no naturally honey-thick liquids and no naturally spoon-thick liquids, such as pudding. This study looked at the aspiration on video fluoroscopy, and there were 190 patients looking at dysphagia, and spoon feeding reduces aspiration more so than drinking from a cup. Mm-hmm. But it would be very, very difficult to feed somebody enough liquids in a day from a spoon to keep them hydrated. So thickened liquids, this study looked at outcomes data, and there was no difference in pneumonia or pneumonia and death between thickened liquids and thin liquids. More dehydration, UTIs, fever in the thickened liquids group, but it was not statistically significant. Also, compliance really decreases after 5 days. About a third of patients are not compliant with the thickened liquids anymore. So yeah, we can do it in a setting like the nursing home or the hospital, but when the patient goes home, it might be very different. Mm-hmm. This study looked at carbonated water, and that showed to be just as effective in preventing aspiration as nectar-thick liquids, which was very interesting. So that might be an option for patients who like carbonated beverages, carbonated water.
That's surprising. I guess it's the sensation that's different that makes people think more about swallowing, maybe?
Yeah, and it might trigger the gag reflex earlier than regular water does. And that's the case with hot and cold liquids, and we'll talk about those in a few minutes. So let's say our 92-year-old does not have a living will, and her caregivers want her to receive a feeding tube. So let's see what the studies have shown on tube feedings. It showed no reduction of aspiration with tube feedings, and it's actually increasing the risk of aspiration in the case of patients with reflux, diabetes, Parkinson's, and COPD. Potential indications for a feeding tube might be patients that have difficulty with swallowing, just cannot swallow, have inadequate caloric intake, have had a stroke, massive stroke, are recovering from head and neck surgery, have some esophageal obstruction, or a discontinuous GI tract. Those might be indications for a feeding tube in the long term. So a feeding tube might be appropriate in some individual patients, but it should not be an automatic next step when other feeding strategies have failed. And Medicare or Medicaid says tube feedings may be associated with aspiration and are not necessarily a desirable alternative to to oral intake, even if swallowing abnormalities are present. The American Geriatric Society position statement from 2013 recommends to not recommend percutaneous feeding tubes in patients with advanced dementia, but recommends instead oral assisted feeding. So feeding tubes have not been shown to reduce the risk of aspiration, prolong survival at the end stage of dementia, and have shown no improvement in weight with advanced dementia. And my theory is that it is the brain that's not controlling the absorption of the food and therefore overloading the body with excess calories. Not only does it not improve weight, but it actually probably increases the inflammatory response and therefore hastens death. In this study, patients were 2.2 times more likely to develop a new pressure ulcer, and existing pressure ulcers did not heal as well when patients were tube fed. Again, that might be in correlation with the excess calories increasing inflammation. So our 92-year-old with moderate dementia has been losing weight. So what do you do? Weight loss is very common in older adults. In community living Americans, the prevalence is 27% in frail elderly and 13% in older veterans. The nursing home population has almost 50% risk of weight loss.
Is weight loss like falls and bed sores? Is that one of those sentinel events that's reported?
Exactly.
Okay, well that's not very nice.
Yes, so the nursing home survey team looks at weight loss as a sentinel event, exactly. So that's why we need to make sure that we document why the patient is losing weight. So for example, a patient has had kidney failure or heart failure and needed to get rid of some excess fluid. We need to make sure that we document that the weight loss is from the fluid loss. Conversely, if it is truly weight loss, then we need to find out why that is and document the workup that we have done for it. And if it is due to advanced dementia, then document that. Weight loss is a sentinel event in nursing homes at 5% in 1 month or 10% in 6 months. And the assessment in the nursing home is done with a mini nutritional assessment. There are several nutrition assessment tools, but only one, the short form of the mini nutritional assessment, has been validated in nursing homes. All the others have not. And this is the MNA short form. It has 7 components. The most recent definition of malnutrition, according to the Academy of Nutrition and Dietetics, is 2 of the following: either decreased food intake related to energy requirements, or weight loss, or loss of body fat or muscle mass, or fluid accumulation, or decreased grip strength. So it does not include albumin or pre-albumin as an important piece. Causes of weight loss are very common in the elderly because of decreased smell, decreased taste, then oftentimes dental problems, infections, cancers are higher in the elderly, and we don't absorb our food as well as what we used to. Then, in addition to that, any medical problems can worsen weight loss. Dementia is a terminal disease. It is incurable and ultimately leads to weight loss and death. And the mean survival is about 10 years. And when we do the screening tests, they're usually 30 points. So we can measure about 3 points per year on average. But some patients decline at a faster rate and some patients go a little bit slower. But all patients eventually, towards the end of the disease process, will lose weight. So what can we do about weight loss? Make sure that the patient has good dental hygiene And what I usually do is ask if any meal is eaten in its entirety. Some of us are good breakfast eaters, some of us like to eat dinner more than breakfast. So ask if the patient eats 100% of any meal, and if they do, double that meal, the portions at that meal, to make sure that they're getting enough calories. So we just saw a patient who said, "Is it lunch yet?" And it was 3 o'clock, but apparently he was hungry. So we wrote the order to give him snacks between meals because he was losing weight. And instead of writing for supplements, just give him a snack. Then make sure the patient is eating with others. Communal eating increases the appetite and increases food intake. And using colored dishes increases it as well.
Yeah.
These are a list of medications that are used for weight loss. And none of them are FDA approved for weight loss in the elderly. And we don't have patient outcome data except for Megace. And it actually showed increased mortality. So we've moved away from using them. And the surveyors are not so pushy about using weight loss medications as they used to be in the past. And in this one study, comparing mirtazapine and sertraline showed no difference in terms of weight loss. So if the underlying cause is depression, then treating the depression will solve the weight loss regardless of what the antidepressant is that you're treating it with. And mirtazapine is not a great antidepressant, and it actually loses its appetite-stimulating effect at the higher doses and is only appetite-stimulating at the low doses when it has an antihistamine effect. The American Geriatric Society in 2014 came out with a recommendation on medications and supplements for weight loss in their Choosing Wisely campaign. And they recommend against using appetite stimulants or high-calorie supplements for the treatment of weight loss, anorexia, or cachexia in older adults. But they recommend to provide appealing foods, assistance with feeding, and looking at the patient's goals and expectations.
So then, is there no place for Ensure? We should not be suggesting Ensure to families and patients?
Right. Yeah.
Wow.
I actually don't believe in Ensure. I don't think it's optimal.
Yeah.
You know, some patients like it, and if they do, then that's okay.
Yeah.
But most patients don't like it. And, you know, if they want to eat some real food, I'd rather do that.
Yeah.
So this is a chart that compared various different supplements with a yogurt and an orange. And as you can imagine, the taste, number one, was a yogurt and an orange.
Yeah.
And nutritional content was very comparable.
Wow.
Actually, more protein, definitely more vitamin C in the orange and yogurt.
Well, and more fiber.
Yeah.
Okay. I mean, that's pretty telling.
Yep. So just to reiterate that in the end stage of dementia, adding a feeding tube does not improve survival or outcomes. And this study also said no difference in outcomes with feeding tubes. And Cochrane database also says there's insufficient evidence to suggest that feeding tubes is beneficial in advanced dementia. AMDA clinical practice guidelines also says to use natural foods rather than feeding tubes or supplements. American Dietetics Association suggests that we should make the food as similar to at home as possible, considering the patient's cultural background, and to avoid stringent dietary restrictions. And CMS says using wholesome foods and natural foods is preferable over supplements. And in this study, they actually showed that eliminating supplemental shakes, improved outcomes. And with improved or less weight loss. So real food first, again, supplying foods that patients like, including chocolate or homemade supplements. If patients want to eat ice cream, that's okay. This study looked at providing supplement and snacks, and again, less waste, more caloric intake with snacks. So making sure that we look at the patient's goals and what the patient can do. And this was a study that looked at not assisting feedings. And when I read those two studies, I changed my living will actually and put in it that if I have advanced dementia to the point where I cannot feed myself anymore, I don't want to be assisted in feeding. Because I would only be advanced enough when I would not, if I cannot feed myself, then I'm advanced enough to where I'm probably not going to recognize my family members either. Mm-hmm. And then I don't want anything to prolong my life. I would want to die of the first dehydration or UTI that comes along, and then also not be fed if I don't feed myself anymore. So put the food in front of me and the drink in front of me, but if I cannot feed myself anymore, then I don't want anything to interfere with that. But so what can we do in patients who have swallowing difficulties? What we can do is to recommend swallowing between bites to clear any food that's in the back of the throat or in the mouth, elevating the head of the bed when the patient eats, using good oral hygiene. Very hot or cold liquids also trigger the gag reflex earlier than body temperature or room temperature liquids. And strong flavor stimulates the muscles of swallowing as well. Then using the chin down rather than extension of the head. So if you remember ACLS, we used to hyperextend the head to intubate the lungs, so we don't intubate the esophagus. Likewise, you want to put the chin down to swallow things. And therefore, you want to make sure that the cup is as full as possible so that the patient doesn't have to hyperextend the head to empty the cup. So if you have a patient drinking some coffee, you might want to just top the coffee off again and again to, one, keep it hot, and two, that the patient doesn't have to hyperextend the head. Using a straw can be helpful in some patients, but can worsen swallowing in some patients. So I recommend you watch the patient when they first use the straw for a few minutes while they're using it. And if they cough using the straw, then maybe that's not for them. But in a lot of patients, that's a good answer because then they don't have to hyperextend their head. Mm-hmm. This is Swallow Strong. It's a device that was developed here at UW that trains and strengthens the mouth muscles, particularly the tongue muscles. And biofeedback is available on the tablet or the computer that it's hooked to. But oral care is really the cornerstone of preventing aspiration pneumonia. So good dental hygiene, brushing our teeth. The problem in facilities is oftentimes that the caregivers who provide the dental care oftentimes are the lowest in terms of education and oftentimes don't take good care of their own teeth and have not had any training in oral care. So it oftentimes does not get done. And that's a big problem. The Fraser-free water protocol includes dental hygiene as one component of it and allows patients to drink free water between meals even if they have failed a swallowing study. And they have had very good outcomes with that. So with meals, patients have to use thickened liquids if they have been shown on studies to require thickeners. And if they drink anything else other than water, it needs to be thickened as well. But water in and of itself, even if it gets aspirated, just gets resorbed and does not cause any problems as long as the bacterial burden in the mouth is reduced. So the Fraser protocol requires that with meal times and non-water drinks to use thickeners, and then to brush the patient's teeth after the meal and wait 30 minutes before supplying the free water. And I have a question mark next to the 30 minutes because sometimes patients can pocket food for quite a while, so they might even after 30 minutes still have some food in there. So you need to really watch them when you do the oral cares after meals that they have cleared all of their food out of the mouth. The inclusion criteria in the Fraser Free Water Protocol included patients on NPO status or on thickened liquids. They were able to swallow water without excessive coughing and staying alert and aroused, and had a timely and efficient swallow, and are able to maintain an upright posture. Exclusion criteria included pulmonary problems, fever, recent pneumonia, unable to get out of the bed consistently, that has to do with the sitting up portion, and then oral infections that would increase the bacterial burden in the mouth. Other things that we can do is using ACE inhibitors. Through the bradykinin pathway that causes the cough with ACE inhibitors, it also protects the airway in patients with swallowing difficulty. And in my experience, when patients have swallowing difficulty, they will not have a cough on the ACE inhibitor, even if they had a cough previously on it. So I have successfully changed several patients back from an ARB to an ACE and got some protection for them. So remember the hyperextension for the intubation and to use the chin down for swallowing. Likewise, a lot of patients who have trouble swallowing pills, when I ask them how they swallow pills, they show me that they hyperextend the head. Mm-hmm. So then teaching them the chin down position oftentimes allows them to swallow their pills. But other things that can help is to use carbonated beverages, use a bottle with a small opening, and using a banana or applesauce. It makes things go down easier. Just to touch on achalasia, it's a spasm of the lower esophageal sphincter. It can be treated with a calcium channel blocker because it relaxes smooth muscle. But calcium is a very effective calcium channel blocker and also relaxes smooth muscle. So I have actually treated it with just Tums very effectively in my patients. And I actually just, when patients have symptoms of things getting stuck here, I just put them on Tums twice a day and see if that improves matters, and I've had good success with that without doing any major workup. So in conclusion, look at the whole patient and the family. Start with the end in mind. Use video fluoroscopy and other studies in the context of the clinical picture and the quality of life and prognosis.